for the person and the rename, just so that we have Ron and whoever the other party is. Okay, perfect. Hello, and thank you for joining us for the second of our two-part series on infection prevention in long-term care communities. For those of you who don't know me, I'm Brenda Roberts, Director of Quality Assurance and Education for the Michigan Assisted Living Association. In recognition of International Infection Prevention Week, MALA is proud to partner with ActivePure Medical to host this educational webinar series to highlight the importance of infection prevention in assisted living facilities and discuss some of the new ideas and technologies that are out there to help us. This is an issue that we know is important to our members, but especially right now as assisted living communities have been hit so hard with the COVID pandemic. And we appreciate everything all of you are doing to keep your residents safe. We've been getting feedback, excellent feedback, from part one of this series, which aired live on Monday with Dr. Deborah Birx, former coronavirus chair, and John LaRochelle, an infection prevention expert. We have another great group ready to talk with you today. I'm excited to welcome back our moderator, Ambassador Jim Glassman, who is going to give you some background on our panelists and kick this off. Jim is a former U.S. Undersecretary of State who has been deeply involved in public health issues for the past 20 years. He had a long career in journalism as a publisher of the Atlantic Monthly, editor of the congressional newspaper Roll Call, and the host of the weekly CNN program, Capitol Gang Sunday. Thanks for joining us today. Jim, I'll turn it over to you.
Thank you so much, Brenda. As Brenda said, this is the International Infection Protection Week, and I think there's no better time to be discussing these issues. And as most of you on this webinar know, America's nursing homes and other long-term care facilities have borne the brunt of the COVID pandemic. With fewer than 1% of the population, nursing home residents account for 1/3 of all COVID deaths in the United States. And Dr. Birx was very, very flattering in her praise of nursing homes and the people who work there. The vaccine is helping. There's no doubt about that. Nationwide, 85% of residents are fully vaccinated as of October 3rd, as well as about 70% of staff. And as for Michigan, last month, Governor Whitmer proposed $39 million for infection control in nursing homes as part of her Michigan Healthy Communities plan. And that includes, of course, money for improvements to make interior air safe. But we have a special message now from State Senator Jeff Irwin. So can we roll that?
Hello, and thank you for joining this course today. The work that you're doing every day on the front lines, keeping people safe, trying to control infections is incredibly important work. And so I really appreciate you spending some extra time to participate in this event today. And I just want to tell you what a big difference it makes when we've got folks who really care, who are out there, who are every day keeping people safe. It's especially important now with COVID. It's really in our face, but this is something that's been important all along. And your efforts every day, keeping people safe from infection, is keeping people alive. It's keeping people healthier and happier for longer. And it's greatly appreciated. So thank you for everything you're doing, and thank you for being here today.
And thank you, Senator. Before I get to introducing the experts for today, I just want to repeat something that Dr. Birx said yesterday that I think is so important. We're seeing a decline in the overall U.S. caseload. It's dropped pretty dramatically, about 25% in the last 2 weeks, but this may well be the calm before the storm. I mean, last year, the worst surge occurred in the winter. And as Dr. Burke said, the current high caseload, we still have a high caseload despite the decline. Even though it is decreasing, it raises significant concerns for the fall and winter of 2021. And I think that's very important to understand. We've also had a very mild beginning of the fall. In fact, the mildest probably in 150 years. And most likely that's not going to continue. And certainly what we see is that more cases develop and more hospitalizations and more deaths, the more people are inside. And as the weather gets colder, people move inside. And certainly in your facilities, people may be inside 100% of the time or close to 100% of the time. So let me introduce our two experts for today. First, you're going to hear from Dan Marsh, my friend Dan Marsh, the president of ActivePure Medical. ActivePure is the company that's developed technology called advanced photocatalysis, which deactivates the COVID virus and other pathogens in the air and on surfaces. Dan himself specializes in developing and implementing integrated disinfection solutions for healthcare companies. He knows healthcare. He spent 40 years in healthcare management. He was previously executive vice president and general manager at PDI Healthcare. And next you'll hear from Ron Payne, the CEO of Southwest LTC Management Services, a startup company that he owns. LTC owns, operates, and manages skilled nursing rehabilitation and assisted living facilities in Texas and Oklahoma. And Ron is the past chairman of the Texas Healthcare Association. He will be joined by his CEO, Kirk Parsons, and Chief Quality Officer, Sandy Hall. After these two presentations, very important, we will have questions from you. And you can send them to us now or at any time through the Q&A button that's at the bottom of the Zoom page. And I should just say for the record that we are recording this webinar. You've all been informed of that. But we're recording it only for our own internal purposes. It will not be publicly distributed. So now let me turn it over to Dan Marsh of ActivePure Medical.
Thank you, Jim. Appreciate you being here today and being supportive of this really, really important topic and all the hard work that's being done out there by the people who have joined us today in terms of keeping the environment of care safe for our elderly population. Before I talk today, though, I'd really like to have Ron tell us a little bit about his organization and his team.
Thank you, Dan. I'm Ron Payne. I'm the CEO of Southwest LTC Management Services. We are owners and operators, managers of skilled nursing facilities and assisted livings throughout Texas and Oklahoma. We've been around since 2003. We certainly always like to pride ourselves in being on the cutting edge of technologies and being ahead of the curve when it comes to issues such as infection control. With me is my COO, Kirk Parsons. We are hoping that Sandy Hall, our Chief Clinical Officer, will be here. Unfortunately, we had a surveyor walk into one of her buildings this morning, and we believe she may be tied up with the surveyor. But I think that everybody on this Zoom understands that issue, and we certainly apologize for Sandy unavailability, but I believe Kirk and I can answer the questions we have, and we look forward to presenting to y'all.
Yeah. So, Ron, thank you. Again, if you could tell us about the breadth of your organization, what type of facilities do you have, and share with us a little bit about the challenges pre-COVID. This industry has all kinds of very, very significant challenges, and we'd like, just before we get into the COVID discussion, I'd like you to share with us what, in your experience, are the challenges that the operators that are on the Zoom call are facing every day?
Sure. Well, as I said, we operate 22 facilities, 17 are skilled nursing facilities and 5 are assisted livings. The challenges are immense that we have in our profession. Everywhere, everything from staffing, even before COVID. As a profession, we had traditionally 100% turnover in our staff on an annual basis. Then you have your regulatory issues, and some states are more aggressive than others. Some are easier to work with than others. You get a state like Texas that had the immense size. We might as well have 5 different states, and the survey process can be different in East Texas versus West Texas versus Dallas-Fort Worth versus Houston. So you have those challenges, and then you have your legislative issues. And unfortunately, most of our legislators really don't understand what it is we do, and their intentions are always good, but sometimes they will introduce legislation that really does not benefit our profession or the public the way they intended. As I said, I think their intentions are good, but perhaps not understanding fully what we do and how things are implemented, it could be a little misguided. And so we have those issues that we deal with. On top of that, you have families that are, they're very scared about putting their loved ones in a communal situation, and nobody wants to. And we have a state representative in Texas who's a physician, and as he always says when he testifies when we're asking for rate increases, I've never had anybody ask me to put them in a nursing home. But you have to do it. And the families are, like I said, they have guilt for having to do it. And sometimes it makes them difficult to deal with. But if you have open communication and, fully, talk to them and keep them apprised of what's going on with their loved one, you certainly can work around those issues. But it's, that's just another example of what we have to deal with.
So healthcare in America changed quite dramatically during the Obama administration. It's one of those 3 sort of milestones in healthcare, starting in '84 with DRGs, and then sort of the movement towards managed care in the early '90s, and then the introduction of the Affordable Care Act. It didn't immediately impact long-term care, but it is really increasingly starting to impact reimbursement through measurements of quality. Can you speak to that a little bit, and what you've how that's impacted you and what you've done to work within that legislation?
Sure. I mean, you actually have to go even earlier than what you had suggested, Dan. I mean, go back to the 60s when we introduced Medicare and Medicaid to the American healthcare system. Back then, life expectancy was about 67, 68 years old. Today, it's 80. Yet we have not done anything in the last 45 years to address our growing population, our growing senior population, our increased life expectancies. And it's putting an immense amount of pressure on both state and federal budgets. In Texas, for example, Article 2, which is Health and Human Services, is now the 2nd largest budget item after education in the state of Texas. And in fact, it probably will be passing education in the next couple of years. I don't know the numbers at the federal level, but it is increasingly difficult. And as we know, the federal government is constantly trying to find ways to control the cost of Medicare and healthcare spending in general. And so when you that puts pressures on whether it's the federal legislators or state legislators to try to come up with ways to reduce the spend, slow the spend. And unfortunately, as long-term care providers, whether it's nursing homes or assisted livings, we get caught in that squeeze.
Understood. And I think it was really important for us to kind of set a baseline in this discussion before we move into talking about the current healthcare crisis, public health crisis, because you're in a challenging industry with lots and lots of different points that pull resources and increase expenses and reduce revenues. So given that groundwork. Can you share with us how the current public health crisis of COVID has impacted your organization, and what were some of the challenges you had to deal with as we moved through the current pandemic?
Sure. Well, when COVID first hit in the late winter, early spring of 2020, we didn't know what it was. Was it a surface virus? Was it an airborne virus? The initial thought was it was surface, and so everybody was going into immense amounts of disinfectant and the hand sanitizers. The governments didn't know what to do. We went to total lockdown, which causes an immense amount of pressure on the loved ones we care for every day. So much of their well-being is the interaction they have with their families, and that went to a complete stop. We try to get very creative with how we could continue to have connection with their families and loved ones, whether it was through something like we're doing right now as a Zoom call, or we were doing it through Windows. We were trying our best to be as creative as humanly possible. We were setting up stations in our parking lot where we'd have a table and we'd bring the resident out and the loved ones come. We'd have a plexiglass between them. They could at least see each other. The states didn't know what to do. Texas, I think we went through 27 edifications of new infection control policies. And Kirk can address that here in a second about how many different ones we as a company wrote in a period of a few months to maintaining compliance with what the state was asking for. The states were very aggressive in the regulatory side in terms of making sure we were doing what we were supposed to be doing, yet they didn't know what we were supposed to be doing. So that made our lives very difficult. Staffing became a challenge. Our staff got burned out. They're in there 24/7, having to wear, full PPE, the N95s, and maybe this on Zoom has worn one for a long period of time, but it's a tremendous amount of pressure on your nose, around your ears. It got very difficult having to deal with having to constantly be on that. And surveyors were in buildings just waiting for an aide or a nurse to pull the mask down for a second, and then they'd write a citation. So that made all kinds of challenges. Back to staffing, again, they got burned out, a lot left. A lot of them had childcare issues with schools shut down. They had nowhere to put their children. Daycares were shut down, so they left the workforce to stay home with their children. People obviously were extremely nervous about putting their loved ones in a communal situation, and censuses dropped. I think at the peak, we dropped as a company about 20% of our population through obviously normal attritional death, but you also had COVID deaths. But we just did not have, nobody was doing surgeries. There was no influx of new residents, and it didn't. You can look at the numbers. It was a dramatic drop between early 2020 and the end of 2020. We started bouncing back up quite a bit, and then the Delta variant obviously hit a couple of months ago, and it's caused another drop. Now, fortunately, I think as senior living providers, we've done a better job making our facilities safe and better infection control. Our numbers haven't dropped like they did. The COVID numbers increased to about 2/3 of where the high was in December of 2020. Back in September, I think we were about 2/3 of that number, about 200,000 COVID cases a day across the United States. Yet nursing home cases at the peak was 30,000 cases a day. It only went up to about 6,000 during the Delta variant. So it did show that nursing homes really are a safe place for your loved ones.
Great. Kirk, in your role as a chief operating officer, I can't even imagine what you went through trying to stay up with the need for PPE and test kits and everything else that suddenly was in high demand and short supply. Can you talk a little bit about some of those challenges and what your strategies were to overcome those challenges?
Yeah, it was very intense, obviously. And the battle between the federal guidance and the state guidance and who was actually calling the primary shots, and everybody was deferring to each other and nobody wanted to take responsibility. As Ron alluded to, we started creating an infection control committee with inside of our own organization, having calls at the beginning nearly daily, kind of moved down to twice a week to once a week to monthly now, 27 different policies as different information came available, and it was a moving target. And everyone was nervous and looking for something to give guidance, and we just tried to do the best we could as quickly as we could and be as adaptable to the different guidances that were coming along through the state, federal, and then ultimately the local authorities ended up with the most power, either county judges, mayors, or emergency management systems inside of the local jurisdiction ended up in phase one having the most authority. And sometimes it was conflicting with federal CDC or state guidance. And so walking your way through that was extremely intense, as well as then just trying to operate day-to-day operations, and senior living is intense enough. And then the labor issue, our industry has always been fairly recession proof. And so through the last 5-6 years, our economy has been booming. So that already puts pressure on the labor force and senior living. We do better when the economy isn't as robust because frontline staff, the labor force is more compact. And now then you're having a booming economy, and then you throw the pressure of the infection and COVID and the federal stimulus money to all the different people in America, just really intensified day-to-day operations. And the first phase of it, we just tried to get PPE. That was it. Everybody said you needed PPE. You couldn't get PPE. The supply chain was pretty well locked down. And so we reverted to our normal measures of ordering PPE. Then that became allocated through our general suppliers. And so then we had to refer to a secondary market or even a third level of marketing to try to acquire PPE, which was then elevated costs beyond anything you could ever imagine. And then it went from PPE to testing, the ability to get testing kits. Government was sending them out sporadically, and you were just trying to decide whether you need to buy your own testing system or use the government's testing system and what was right or wrong. And then it became a reporting issue. The demand for reporting all of this information through CDC and NHSN became so burdensome as an organization that you were just striving every day to try to keep from not reporting something you should, making that information as accurate as possible, and so that no one would be looking improperly at your organization through not reporting or not reporting appropriately. And that still continues today. And this reporting mechanism through CDC and NHSN has become something that the federal government is so focused on as giving an eye into your organization from an infection control process that they've never had before. And I think that burden's going to continue on. Then we've now moved through the second phase where everything had stabilized and labor became, the number one focus and still is. And then you have the flight of the quality labor force leaving to go do something else just because they can't maintain this stress and pressure and PPE accommodations to wear to work every day on top of their current uniform has just become quite burdensome.
It's really incredible. When we get these shocks to our supply chain, it's just, we can't stay up with it. And I think there's a lot of work that needs to be done at a federal level to figure out how we can stockpile supplies. This is not our last pandemic. It's not our first pandemic. These challenges are going to be in front of us in the future. And I think the federal government has to take a role in trying to figure out how we can do a better job of making sure we have what we have. Sandy, I'm going to ask you a question. The chaos that came with COVID, caused problems throughout our entire healthcare continuum. The CDC has reported, and the Association of Practitioners of Infection Control have echoed that we are going backwards. The president of APIC actually said that our infection control system has taken a 10-year step backwards. Our rates are at a 7-year high in terms of CLABSIs and bloodstream infections and soft tissue infections. What were the unique challenges that you had as it related to all the chaos of COVID and trying to maintain, a good environment of care?
Morning. Well, first of all, we had to deal with staff burnout, as Ron and Kirk had alluded to earlier. But the second thing that you had was fear. The staff were scared. Their families were scared. You had to try to alleviate that on a daily basis. They were afraid that they were going to get very ill and possibly die. So I was feeling lots of calls on that. And I think that what happened related to infection control is we had to continue to emphasize standard precautions and transmission-based precautions. So the focus was on COVID-19 and preventing those infections, and just the increased workload and maintaining that, monitoring, screening, testing, all those activities that the gentleman earlier alluded to, is people forgot about other infections. We forgot about the other parts that are going on with the residents' day-to-day care, the areas of their care, and other infections that are still available to be a source for a problem for the patient. And I think that's what happened, is everybody kind of just got focused in on COVID-19, and they kind of just forgot about UTIs and anything else that was going on. The main thing was everybody was living and breathing COVID.
Understood. Amazing challenges. Just one unique thing about COVID. In the beginning, CDC said it was droplets and surface transmission. But as the data continued to come out, we began to better realize that it was an aerosolized virus. We have had to deal with aerosolized viruses and pathogens before, but not to this extent. So for the first time, we had to think about what are we doing about the air in these occupied spaces. Ron, or anybody on the team, just speak to what your choices were and what you did.
Well, early on, there weren't a whole lot of options, or at least not that we were aware of. We thought it was a surface, so everybody knew to sanitize and to do those type of steps. But then we were fortunate. You and I personally known each other a very long time, but was unaware of what ActivePure Medical's what your airborne system could provide. But now you are seeing, not only your organization, but other organizations have these technologies that can go into your air systems and help, minimize, all your airborne viruses. And, that's what we're seeing, a tremendous improvement. What you did in our Oklahoma buildings has been phenomenal. And in terms of the reduction down to negligible amounts of pathogens in the air. And I think if there's one good thing that came out of COVID, it has taught us, to take a better, a more stringent look at our infection control policies and how we look at these pathogens, whether it's surface or airborne, and taking the measures to be able to minimize the effect of them. And one of the issues, obviously, is the cost associated with being able to implement such technology. We were very lucky in Oklahoma that during the pandemic, they took some funds and were providing grants to long-term care facilities to use for infection control specifically. So we were able to use those funds and contracted with y'all and implemented, the system in several of our buildings. We're looking forward to doing it in the rest of the buildings. It's just like so many other things in long-term care. And we talked about, the funding issues. These are unfunded, needs. And so where do we find the ability to be able to afford to get the best and highest technologies to keep our residents the safest we can keep them?
So as Ron has shared with you, they took a very aggressive tract of implementation of technology in their Oklahoma facilities. If I'm going to take you through a little bit about what they did and some of the results of what they were able to do. Before I go into the technology, I just want to level set exactly what we talked about on Tuesday, which is next. You can't disinfect what you're not cleaning. And the thing that I noticed very quickly in working with Southwest Long-Term Care was that they had implemented essentially hospital standards in their facilities. It's very, very important. And John LaRochelle talked about it on Tuesday, but we made lots and lots of changes over the last decade in terms of how we clean and disinfect the environment of care. All of you need to understand that the speed with which and the ability to kill up and down the hierarchy of pathogens in your disinfectants is really, really important. Historically, we used disinfectants that took 10 minutes. Most of them now, if we're using the right ones, the dwell time is between 1 minute and 3 minutes. It's also important to make sure that you have a sporicidal within the claims of that EPA label. The other thing that we learned through a lot of research in hospitals was that using reusable rags, using string mops is all we're going to do is spread the pathogens. Very, very important that we're using, if at all possible, disposable substrates. If not, we're going to use microfibers that are being laundered at high temperatures so that we are making sure that every time we apply a substrate, we're getting a good, clean, disinfected carrier of the chemicals so that we're not spreading pathogens around. But when I came into the facilities with the team, the thing that was very evident is they were all highly trained, had protocols laid out for them in terms of what they were to clean, high touch points. And that's really, really important that we dictate to our EVS cleaning and disinfection crews exactly what their job is and exactly what they should be doing. And the last thing that I would highly encourage everybody to think about is implementing some kind of monitoring into the process. There's and I can share this with anybody that's interested, but there's very efficient, effective, and simple ways of, we call it magic dust. You can pre-populate high touch points with magic dust that only shows up under an ultraviolet lamp. It is a very good way for the senior nursing team to monitor what is going on a daily basis on the cleaning and disinfection. And it lets everybody know that their work's being watched. And we all know, what gets measured gets done. So this is what I was very excited about when I walked into Southwest Long-Term Care is they had implemented many of these strategies, and the facilities were very, very, very clean. But what's happening in hospitals is trickling down into the others continuum of care. What all the thought leaders are calling for now is a demand for supplemental and in many cases no touch technologies. Dr. Rotala is the author of the CDC's guidelines for cleaning and disinfection, the environment of care. He and his other thought leaders, Dr. Chen, Dr. Donsky, are all calling for the need to develop technology that first and foremost provides continuous disinfection or persistence into the environment of care. The second thing that's really, really important when you talk to them is they understand that humans are fallible. They absolutely are calling more and more for technology that can engineer out the human factor. There's no matter how well we train and how much we monitor, there's lots and lots of locations that get missed. The problems we're solving for are, that can be summed up in three. Number one is we got to make sure that we're doing something to take care of inadequate disinfection. And again, that's the human factor. Even though we say we need to do this, it doesn't always get done. Research says 50% of the time we miss the high touch points that we were supposed to do. The second thing, and this is the research is really pointing this out today, is that episodic once a day cleaning and disinfection is inadequate. We recontaminate the environment of care literally dozens and sometimes hundreds of times a day. And then add into that the current public health crisis. We know that we need to do something to deal with the aerosolization of pathogens and virus. And again, keeping all of that in, especially in a time when labor is such a huge issue, trying to find technology that can help us engineer out the human factor is really important. This is a graphic demonstration of our technology. It's not passive. There lots and lots of hospitals and healthcare facilities have employed passive air filtration. This points out some of the problems with passive, and then goes on to talk a little bit about what we do, which is we fill the environment with highly effective oxidative molecules at very safe levels, at very, very low levels, but highly effective.
This is how pathogens such as SARS-CoV-2, the virus responsible for COVID-19, spreads throughout a waiting room from patient to patient if untreated. Slow and ineffective technologies like HEPA filters or UV lights only treat the air that goes through the filter or the virus and bacterium directly exposed. ActivePure technology takes a proactive approach by continuously filling the room with powerful molecules, including gaseous hydrogen peroxide, that quickly attack harmful pathogens as soon as they enter the space. ActivePure is effective against a broad spectrum of airborne and surface pathogens.
So that's a very graphic explanation. What we're doing is creating molecules that are continuously entered into the space that attack viruses in the air and then settle down on surfaces where they also reduce pathogens. The team at Southwest Long-Term Care employed predominantly two devices. The one on the right is a induct unit, and the one on the left is the Medical Guardian. It's an FDA cleared Class 2 medical device. What these devices do, they're very, very simple photocatalysis. As the air passes through, it takes the water molecules in the humidity and breaks them down and reforms them into these oxidative molecules. So I'm going to talk a little bit about what we did at Southwest Long-Term Care and to demonstrate the effectiveness of the product. Prior to any sort of implementation, we put together a study design. The idea was to first test and find out what the environment looked like prior to the implementation. And then the study design was designed to look at three things: average microburdens in the environment, locations with more than 500 CFUs in the environment, and then also the most predominant pathogen that we all worry about, whether it's in a community or in the healthcare setting, is MRSA. It is ubiquitous, and in an aging population, it leads to more than 50% of the bloodstream infections and soft tissue infections and urinary tract infections. Again, one of the things that we looked at, and this comes from work done by Dr. Ratala, is the benchmark that we're looking for is you can't sterilize the environment of care. It's impossible to do. So we want to keep it as clean as possible. And sort of the break-even point we say is 500 CFUs. The research tends to show that when we're doing environmental testing of 100 centimeter squared spaces, if we can get an average count of less than 500 CFUs, we're going to have a much lower infection rate. So it is once you get above that in your testing that you start to find a correlation to higher infections. So basically what we did is we did a baseline environmental testing where 20 locations were swabbed and sent to microchem labs to be analyzed. We then put in the equipment and let the equipment run. And then about 2 weeks later, we came back in to see what the impact was on those baseline microburden levels. In the initial baseline, in 20 out of 20 locations, we found Staph aureus, MRSA. In 9 out of 20 locations, that MRSA count was greater than 500 CFUs. And again, this is in a pristine, very well managed facility. It is just healthcare. Over 40% of the population carries MRSA in their nares, and this is something we all have to deal with. And it's why daily cleaning and disinfection isn't enough. We have to have something that is providing continuous reduction. So post-activation, the results were dramatic. In case of MRSA, the location, the average level of MRSA was reduced by 96.67%. Bacteria in general was reduced by 96, almost 97%, and fungi was reduced 98%. The thing that we were most excited about is when we talked about that sort of benchmark measurement of 500 CFUs. With MRSA, we took it from 9 locations with greater than 500 CFUs to 0, which was really, really dramatic results. Bacteria went from 12 locations to 4, and in fungi, it went from 16 locations to 4. Really important to understand here, we're actually doing our baseline studies and the post-study in an occupied space while people were working and living, and we were able to get these results. Again, the goals we had set, which are reduction in microburden, 97%. Reduction in locations with greater than 500 CFUs was 81%. And the incident of MRSA was reduced by 30%. But keep in mind, we reduced the average MRSA count well below anything that would be considered highly, highly infectious. And the overall count was reduced by 97%. Okay. There's another element to this also, and I think everybody has alluded to it a little bit today. Not only do we have a scientific problem of fighting infections and fighting pathogens in our environment of care, but in today's environment, we're worried about how do we keep the staff feeling like the organization has done something to keep their environment safe. And the same thing that Ron talked about, which is how do we get our families comfortable with the fact that they're putting their loved ones in the home and in the facility. And so there's a big part of adding capability within the organization to not only fight the pathogens, but to give everybody a sense that the environment is safe. And it helps in so many ways with both the guests and the staff. In this present public health crisis that we have, we know that the COVID virus is aerosolized, and that's where we attack it while it's still up in the air. Should any be on surfaces, our molecules eventually settle down to the surface and go to work on them there as well.
That's one of the great things about this technology is it really alleviates some of the burden from our staff because we're very particular about making sure that we are clean and we keep everything safe for our residents and our staff. And this technology is going to make it a lot easier to keep that a reality.
I was so happy to walk into this facility today and see the welcome sign. You can tell that the staff is excited to be here. You can tell that the patients are happy that they have visitors allowed again. And the facility is doing absolutely everything they can to ensure that the patients aren't only happy, but are protected and safe. They're doing COVID testing to any visitor. They're scanning temperatures of everyone walking in and out the door, even employees on their lunch break. They have COVID paperwork that they fill out. They have hand sanitizer throughout. And as of today, they have ActivePure technology installed throughout the entire facility, providing continuous and automated surface and air disinfection.
It's really nice to have that unit at the nurses station because we can point that out to our residents and our visitors when they come in so they can feel more comfortable with being here and visiting and just the protection of their loved ones so they don't have to worry as much about bringing something in.
They're able to educate every visitor and let them know that they have installed continuous surface and air disinfection to protect all of the patients all of the time. Even as SARS-CoV-2 becomes a thing of the past, there's still community-acquired infections and hospital-acquired infections that we are able to protect them against, like the common flu or strep throat or staph infection. We're here to help their staff and patients feel confident in the decision made by their company to protect them.
Jim, I'm going to turn it back over to you.
Thank you. Thank you. That was an excellent presentation. I just want to go back to one of the things that Ron said, that COVID has taught us to take a more stringent look at infection control policies. And Marissa there at the end was talking about flu. I mean, COVID isn't the only problem, obviously. Do you feel Dan and Ron that you are better prepared for flu and some of the other kinds of dangers that we're going to be facing in the next few months as a result of what you've done with ActivePure here?
Yeah, and I'll let Kirk and Sandy, from a clinical standpoint, address that. But the short answer is yes. Obviously, with the screenings that we do going into the building, we're still requiring masks within the building. Yes, we are better prepared. The ActivePure, is continually, cleansing the air, so to speak. And so as Dan's, data showed, our pathogens are reduced dramatically and will continue to do so, which should fight all viruses, whether it's COVID or any MRSA. And I know Kirk would address this, but our infection rates have been tremendously better since since we implemented the system in Oklahoma.
The science, obviously, the testing spoke for itself, and the cleansing of the air and even the surface contact. But the eye test is really important from an operational standpoint. Here we are in the season of college football, and the selection committee always talks about record competition and then the eye test. And if you just look at the operational side, the facility that was shown in the video there was in the second phase of the outbreak early summer. We had 3 buildings that had an extreme outbreak of COVID. And that particular building was the highest outbreak we had in our organization. And that was prior to the installation of the equipment. And then through this last phase of infection, we have had 0 outbreak in residents. Now, that doesn't happen in a vacuum. Obviously, you had vaccinations and you had people that had COVID and had their own natural immunities to a second infection. But nonetheless, all of those things combined, the eye test proves that scrubbing the air and having an active versus a passive mechanism of controlling infection clearly works.
You know, just as a follow-up to that, what about confidence? You talked a little bit about that earlier, about making people aware of the changes that you made, but how do you do that? I think facilities managers would really like to know, what are some of the ways that you're telling people, you know, we're cleaning the air for you?
Well, it's every day. Like every day, you have to make that a forefront of your marketing and your advertisement. You have to have it through your resident council and family council meetings as best you have during this time where your normal access isn't typical through teleconferencing and thing. And you just have to remind them of the statistics that you have internally, and you have to communicate and talk about it constantly, about what all we're doing to keep everyone safe, not just the residents, but the safety of the worker in the workplace is critically important during this time.
But do you have signs or brochures or other kinds of materials that say that you know, ActivePure is present? Obviously, you can't see these molecules at work, so you have to remind people that this is happening.
We have the video posted on our websites, and we have material in the building, and obviously they can see the machines that are displayed at the nurses station. They cannot see the ones that are housed inside of the HVAC systems, but you just have to talk to them about it.
So I just want to remind everyone that we only have 8 minutes left. So if you have questions, please send them along. So one question that we have is about, and I should address this one to Dan, is in the video, you could see the little representations of the submicroscopic particles that are deactivating the bad guys, the pathogens. And you mentioned that you're generating low levels of hydrogen peroxide and other things. How do we know that that the air is safe? In other words, that there aren't any other kinds of compounds that are being generated, or even ozone? Dan, what's the situation on that?
That's a really good question, Jim. I appreciate you asking. So as we spoke, the Medical Guardian is an FDA cleared product. The FDA, when they clear it, they focus on two words: effective. So if we're making claims about being able to kill staph and strep and viruses and molds, the FDA puts us through a battery of independent lab testing in which we follow very strict protocols for ASTM generated tests that demonstrate our ability to reduce pathogens in a validatable and repeatable way. But the other word, and I think sometimes the FDA focuses on this one more than they do on the other side, and that is safe. In order to get the clearance, they test the technology to make sure that the levels of technology that we're creating, the molecules that we're creating, are well within any standards required by OSHA or NIOSH or International Association that lays out what hydrogen peroxide can do. The second thing that they do is they put us through a battery of tests to demonstrate that we aren't creating any VOCs. And as it relates to, you brought up specifically ozone, all of our products are CARB approved, which is the California Air Resource Board. California has a very, very strict protocol that you have to go through to prove that your devices are not creating ozone, that your devices are not creating any sort of VOCs, that you are in fact safe. And so there's a number of different organizations that all weigh in on this UL listing, but basically, you know, we are a medical company, and in many ways, our ability to regulate ourselves is the most important. And we do constant testing to make sure that what we're putting into the environment is safe and effective. And just to put it out there as it relates to what is it. We're putting out 0.01 to 0.03 parts per million of hydrogen peroxide, gaseous hydrogen peroxide, which is very similar to what you would find on a sunny day near the beach. Our own atmosphere does a really good job of cleaning up our environment. And what we're trying to do is replicate that in a way that can be used safely and effectively in inhabited spaces.
Yeah, and I think that's a really good point you make at the end there, Dan, that, you know, I've heard it said that really what happens is that outside air, this is a way to kind of create air that's as clean as outside air, as far as pathogens are concerned, inside. That the sun does a fabulous job of eliminating a lot of dangerous things in the air outside. And the ActivePure is doing the same kind of thing indoors. I just want to say that I think somebody raised a hand, and with a question, I don't want us to miss that question. So whoever that was, the hand is now down. If you could just type up the question briefly in chat or in Q&A, that would be great. I would appreciate that. Because we don't have that much time left. And the question I did want to ask was, and I think this is a good one for Ron and team, has COVID forever changed the way that your teams look at cleaning and disinfection?
Absolutely. You know, whether it was opening our eyes, additional regulatory requirement, but yes, it has. I mean, we now have more stringent infection control regulations than we've ever had, which is, you know, I mean, it's a burden, but it's not bad. You know, it's something that needs to be done to protect the loved ones that we take care of every day. And those standards are not going to be relaxed. And so we are all going to be challenged to continually improve our infection control policies. And I think the public in general wants to see us improve and make our facilities safer for everybody.
Good. I have another question here for Dan, and that's about absenteeism. I guess it's really for your group as well, Ron. I mean, what is the evidence of generally reducing absenteeism among staff through the use of this kind of technology that we're talking about?
Yeah, it's a great question, and it's an important thing that when I started to work with this technology, the science of this technology and the reduction of pathogens, you think about how it's going to improve the outcomes of our patients' experience. But the side benefit is the employees also get the benefit. We've done studies in hospitals and even in schools where we've consistently demonstrated our ability to not only make the environment safer for patients, but the side benefit is that guests and staff are also safer. We reduced absenteeism rates consistently in both schools and healthcare settings after the implementation of this technology.
Great. Have you seen evidence of that, Ron, and your team?
There's some facilities we have. We've over, what we call agency labor, which, is the temporary agency we get from outside sources, is on a tremendous uptick across our entire profession. But we have facilities that have very little of it, and a lot of those facilities are facilities that we have used, the ActivePure system. And I think it's, I haven't per se canvassed the as that's the reason, but when you do talk to the administrator of the DON, you do know that their communication level with their staff is at an enormously high level, and they're telling them and convincing them that they are providing the safest place for them and the best place for them to be, and you are seeing a more stabilized staff.
Great. Well, it's exactly 1 o'clock Eastern time, so we have to be ending. I don't know, Dan, if there's something you have to say, please Let me
Just a
turn it
quick
over to
15
you.
seconds. First of all, kudos to everybody that's out there working on infection prevention, and it is a journey. It is not a destination. We're only going to get better if we look for incremental improvement. And I want to congratulate Southwest Long-Term Care, Ron and his team, for engaging in that journey and demonstrating that you can get better today than you were yesterday.
Dan, thank you for those words. We appreciate everything your organization has done for us. It's helped us tremendously with making our places safer for our residents and our staff. And I highly encourage anybody watching this to reach out to Dan and his team. And it's fantastic technology, and it's one you should be trying to implement in your facility. And Jim, thank you for hosting and moderating, and we appreciate the ability, the opportunity to speak to everybody today.
Great. And I think we have a slide. Well, there's a slide thanking everyone. And then I think there may be something about further information. But thank you all.
Thank you, Jim. Appreciate it.